Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today I have with me Dr. Luciano Costa, an established authority in the world of multiple myeloma at the University of Alabama. He leads the myeloma program there, and he's going to talk to us about the new GPRC5D targeted CAR T cell in development. So, welcome, Luciano.
Thank you very much, Ravi, for having me, and thanks for the chance to share those developments with your audience.
So, first, just to lay the groundwork, where are we with CAR T cells today?
Yes, I mean, I think if we just watch the developments the last 5 years, it's really an amazing pace. I think in this very short period of time, CAR T cell therapy, became a very, ambitious hypothetical future to a very established reality. We have now in the US two approved CAR T cell treatments, ide-cel or Abecma, and cilta-cel or Carvykti. And those therapies were approved initially for patients with 4 or more prior lines of therapy. So really as kind of a last resort alternative to treatment. But given the results of two large randomized phase 3 trials, they have now been approved in earlier lines of therapy. So in the case of cilta-cel for patients with 1 or more prior lines of therapy whose disease has become resistant to lenalidomide, and for in the case of ide-cel for patients with 2 or more prior lines of therapy whose disease has been exposed to an immunomodulatory agent, a proteasome inhibitor, and an anti-CD38 monoclonal antibody. But Ravi, as you know, those two therapies are somewhat different among themselves in terms of side effect profile and activity, but they all target the same myeloma protein, which is BCMA. So the challenge and the opportunity here is to develop a therapy that perhaps could be equally or more effective, but that goes after an alternative target in order to increase the treatment opportunities for our patients.
Can you tell us about this target?
Yes. So as we know, any cell is covered with a lot of different proteins that are sitting on the membrane or through the membrane, and that serves different functions on that normal cell. And through immunotherapy, we explore several of those proteins as being targets, either for naked monoclonal antibodies, as we have for CD38 or SLAMF7, for antibody-drug conjugate, or for bispecific T-cell engagers, or for CAR T-cell. BCMA is perhaps the most famous of all because we have now 4 different FDA-approved therapies, 2 bispecific T-cell engagers and 2 CAR T-cells, plus an antibody-drug conjugate that was briefly available a few years ago and might come back in the near future, given the positive results of 2 large phase 3 trials. And BCMA is an essential protein for survival of the plasma cells and the myeloma cell. Now, GPRC5D is essentially G protein receptor complex 5 subunit D, is a receptor by its conformation. It looks like one, but nobody knows the target. Nobody knows the ligand for that. And it does not seem to serve any particular function on the plasma cell or on the malignant plasma cell. We know that is an important target for myeloma therapy because now we have a bispecific T-cell engager, talquetamab, that produces high frequency and depth of and durable responses that is directed at GPRC5D.
what can you tell us about this trial?
Yeah, so Arlocel is a autologous uh, CAR T cell that has affinity for GPRC5D. This study that has been presented a few times, mostly by my UAB colleague, Dr. Ball, who updated this data at the ASH 2024. In this particular cohort, include patients with 3 or more prior lines of therapy that include all the established agents, PI, IMiDs, and anti-CD38 monoclonal antibodies. As established for other autologous CAR T cells, those patients undergo apheresis, collecting mononuclear cells that will yield T cells for manufacturing of the CAR T. They had the option of undergoing some bridging therapy, which is, some therapy in between to keep the disease under control if necessary, and reduce the disease burden. Then they underwent a standardized lymphodepletion that, as you know, doesn't necessarily serve a role into treating the myeloma, but creates a very lymphopenic environment with the proper cytokine milieu that yields to fast expansion of those T cells when they are reintroduced. And then 3 days after completing the lymphodepletion, patients receive a dose of Arlocel. Because this was a dose-finding trial initially with then subsequent expansion, we treated patients at all doses ranging from 25 to 450 million cells. None of those doses were considered to be non-tolerated, but due to a confirmation of a combination of factors, including safety, expansion, and activity, the dose of 150 million cells were chosen for expansion. And of course, we pay close attention to the safety, but also measure the activity through different parameters of response and duration of response.
So, how did patients get onto this trial, and what dose levels did they receive primarily?
Yeah, so 86 patients entered the study. 2/3 of them received bridging therapy, and 1/3 went on to receive Arlocel without any bridging. And only 2 patients who entered the study did not receive Arlocel. And I think that is a finding on itself. If you look at the pivotal trials that led to approval of ide-cel and cilta-cel, we had at least 10% of patients have attrition between the bridge, the eligibility and the infusion, perhaps due to manufacturing failure, perhaps due to patients' condition deteriorating. And I think there's a steep learning curve on managing this therapy and timing those patients. And I think that shows itself with its very low attrition rate. Of the 84 patients who receive infusion, some are at the extreme of low and high dose, but most of those patients are at 150 million cells or 75 or 300. And overall, we arrive at 79 patients who have enough follow-up, receive the cells that have enough follow-up to be evaluated for activity.
So, what were the characteristics of these patients?
Yeah, so as you would expect in this day and age, everybody had been exposed to PI, IMiD, and anti-CD38 monoclonal antibody. That it was as a function of the eligibility. There was a high proportion of patients, over 40% of patients, with a classic, high-risk chromosome abnormality, either deletion 17p or translocation 414 or 1416. And overall, near half the patients had extramedullary disease with a median 5 prior lines of therapy. So undoubtedly a heavily pretreated patient population. I think, Ravi, you would relate to this. I think if we were doing a trial like this 3 or 4 years ago, we wouldn't have any patients with prior BCMA-directed therapy. But just because we now have, those agents available and other BCMA-directed CAR Ts available, it just turned out that near half of the population in this study had received prior BCMA-directed therapy. The most common, of course, being a prior CAR T. So it's a very, heavily pretreated patient population.
How did patients tolerate this?
It was quite interesting. I remember the early days of this program. We already knew about the on-target off-tumor toxicity we see with talquetamab, with the dysgeusia, the nail changes, the skin changes. And we had a healthy fear that with CAR T cells in general being more potent, we would encounter a very high frequency or high severity of those side effects. And it turns out that was not the case. We saw, neutropenia, anemia, thrombocytopenia, mostly related to the lymphodepletion chemotherapy. And many of those achieve grade 3 or grade 4, but they are of short duration. Very few of those beyond the first month after treatment. Infections were somewhat uncommon, particularly high-rate infections. And this has something that you and I know has been seen also with the bispecific T-cell engagers, that those targeting GPRC5D seems to be associated with a lower risk of severe infection than those targeting BCMA. And we had about a third of the patients, a little bit more, experiencing the dysgeusia, the nail changes and the skin changes than we see with talquetamab. So in that regard, this kind of GPRC5D unique adverse events seem somewhat less frequent than it does with that it is with the bispecific T-cell engagers.
What about the more classic toxicities due to CAR T cells and the targeting of GPRC5D?
Yes, so we saw, I would say, a pretty kind of expected profile. Most patients have CRS, 82% in the whole study, but only 3 patients had grade 3 or 4 CRS, and it all resolved with treatment. ICANS was seen in 10% of the patients, but again, in only 2 was of a higher grade and reverse. We had a plethora of other neurotoxicity events, something that we're starting to see also with talquetamab. And in 6 of those patients, there were grade 3 and grade 4. And that is a constellation of symptoms, particularly dizziness, some ataxia, some dysarthria. Some of those resolve or improve. Some of those are ongoing. So I think we're going to have to treat more patients with longer follow-up to learn more about those neurotoxicities, and particularly how to manage those. And the skin, nail, and oral toxicity was seen a little bit less than a third of the patients. And in the vast majority was minor and resolved over time with a with a great variety of time for resolution. But it seems somewhat very of a lesser magnitude than we are accustomed to see with talquetamab.
And how effective is this treatment?
Yeah, so that's where everything started making sense, right? When you combine the knowledge of the toxicity with the efficacy to ultimately appraise this is a worthy treatment. And the response rates were very high, overall 87%, 91% are recommended phase 2 dose. Most of those responses were complete response or very good partial response. And interesting, the duration of response was about 18 months. So in average, patients maintain disease control for a year and a half, despite the fact that it's a heavily pretreated population, and despite the fact that this is a group of patients where many have received prior BCMA-directed therapy. As you can see, the efficacy seems equally high on patients who are triple-class refractory, patients who had extramedullary disease, patients with high-risk cytogenetics. And I think it's a very elegant demonstration, Ravi, of how BCMA and GPRC5D are totally independent, non-connected targets, to see that the activity, not only in the rate of response, but the duration of response, was nearly identical between BCMA naive and patients with prior BCMA-directed therapy, showing that those targets are independent. Patients can benefit from both, and there's not a natural sequence of how those targets can or should be explored.
And so how about the survival?
Yeah, so that's another, I think, reassuring finding that we had. A median PFS was 18.3 months, after a one-time single-dose therapy. I think it's something to be encouraged by. Of those patients, the majority achieve MRD negative complete response. And the overall survival has not yet been reached. And if you look at 12-month overall survival, 90%, 18-month overall survival, 87%. And I think when we look at this, Ravi, the fact that the PFS is quite reasonable, quite encouraging, yet the overall survival is even better, I think tells us that this is not necessarily a last therapy that our patients might receive. And it speaks for the safety of this agent, the fact that the patients are not left with prolonged and profound cytopenias, and they can still go on to receive other therapies beyond progression and continue to stay alive and benefit from future therapies.
So what's your key takeaways from this trial?
I mean, I think we're all, of course, very excited about this program. I think despite the fantastic improvement on therapy, there has been the BCMA-directed bispecifics and CAR T cell. There is still clear that we need better and different options. And it's really refreshing to see something with this safety profile, with this level of activity that can and hopefully will soon become a reality for our patients. BMS that makes this CAR T product is heavily invested in this program. We're currently accruing to a registrational phase 2 trial called Quintessential. And there is a trial that is going to soon be, that has just been launched, a randomized trial for patients in earlier lines of therapy, comparing Arlocabtagene versus other conventional regimens. So I really foresee a future, Ravi, where we have this CAR T available among our armamentarium, and it's going to be up to us to make a choice of when to pursue a BCMA-directed and when to pursue a GPRC5D-directed therapy, and how to do so through a bispecific, through a CAR T, and particularly how do we want to sequence those different options that we have.
So how do you today use GPRC5D-directed therapy, and when do you see this becoming a reality for commercial use?
Well, good question. I mean, today it's the only option we have is talquetamab, which is a fantastic development in myeloma therapeutics, yet with some limitations that we know particularly relate to the toxicity. Because the BCMA CAR Ts are approved in earlier lines and provide such a deep and durable response, oftentimes talquetamab ends up being used post progression after BCMA-directed CAR T. Although there are certainly the patients for which talquetamab would be very appropriate, despite any prior BCMA-directed therapy. Now, I think in the future, who knows, right? If you have an agent like this that can give a one-time therapy and provides a safety and efficacy profile that is similar, not superior to talquetamab, I can certainly see myself opting for Arlocabtagene as the preferred way to approach, GPRC5D, giving, of course, the options that we have nowadays. As for when Arlocabtagene will become available, hard to tell. I think it all depends on the speed of completion of quintessential trial that I can share is going very well, growing very rapidly, and of course how our regulatory agents will take that data. So without any greater inside knowledge, I would make an optimistic prediction that perhaps we'll have that by 2026.
Well, I really appreciate you taking the time to educate our audience on this exciting development. You've had a ringside seat in the development of this CAR T, and looking forward to returning to you to tell us more about this as it becomes a commercial reality.
Thank you so much, Ravi, again, for this is a great opportunity that I very much appreciate.
Thank you very much.